All right, now it's time for questions. Please come to the microphone and tell us who you're addressing your question to. Thank you.
Hi, my question is for Cynthia. You had a very interesting last slide, but you didn't get to cover your ideas on an open platform and how that might be useful for pursuing research and development. Could you say a little bit more about that?
Basically what I was speaking to is developing, especially for wireless technologies, instead of each company have a proprietary transmission and reception system, have it the same so that you can mix and match products.
Okay.
Yeah.
And then, Eric, could you kind of address that approach as well? How would that fit into the FDA's regulatory framework? If somebody had a flexible tool like that where they were able to wire it up themselves to create the transceiver from whatever input signal they wanted to an output signal.
So issue's a little cloudy on the FDA regulatory standpoint because we don't have a specific classification regulations for assistive listening devices. And in general, though, in terms of new technologies within the 510K process, if it falls within or is similar to an air conduction hearing aid or is related to that sort of thing, it could basically, as long as there's not a fundamental change in technology or a new indication for use in new population, there wouldn't necessarily be the requirement for a pre-market notification to FDA as long as those general controls that I went over are complied with. So.
Eric, over here. What would it take for a PSAP to be elevated to a Class 1 device?
Okay, so the word PSAP, I think, was created within a guidance document that we created back in 2009, and it was specifically meant to define a group of products that were not intended to treat hearing impaired consumers. Okay, so as such, it essentially is not within FDA's regulatory jurisdiction. It's a consumer electronic product. So anytime that it would start to make claims in terms of treating hearing impaired individuals, then it kind of crosses the line and meets the definition of a medical device and would essentially be classified as a hearing aid.
So can I ask one follow-up? So the PSAP manufacturers would have to take that step to say, we want to market this to the hearing impaired. So we have to go through the channels to make it a Class 1 medical device?
Well, that's one route. The other route is when FDA does become aware of a device that is being marketed clearly to hearing impaired consumers, and this can take a variety of forms. There may be an enforcement action in terms of you are marketing this device. You may not be explicitly calling yourself a hearing aid, but you are, listing the types of hearing loss, saying a low-cost alternative to a hearing aid, and then in small print, but we're not a hearing aid. Those kind of situations are potentially compliance-related issues in which FDA would say, hey, you appear to be marketing your device to hearing impaired consumers. We believe you are a hearing aid the way you're marketing yourself, so you either have to change your labeling or you need to meet the general controls for a hearing aid.
Thank you.
Hi. So this is, I guess, mainly directed toward, everyone, mainly for Eric, and I feel sort of my role as co-chair is sort of be a provocateur in many ways. So this is sort of following on Barbara's comments, and I think the reason why PSAPs always come up over and over again, I think fundamentally it's the issue of access, right? So I just like to think of two classic examples that always come to mind, sort of clinical practice, my research. I mean, so I'll say I have one patient now is a 67-year-old man. He's a retired adjunct professor from a community college who's essentially on a very fixed income, and he has a moderate hearing loss, and he has $500. That's all he has, right? So we've tried various, maybe the StarKey program, but there are always all these hurdles, right? So he fundamentally just has no access right now to any type of care. And then another example I'll give is someone in my research protocols who is a 72-year-old lady who is disabled. She lives essentially in independent senior living housing, but she can't get around, right? And she knows she's a hearing problem, she wants to do something about it, right? So I think while going forward, I think there are clear solutions in many ways. I mean, I think the role of community healthcare workers can do the counseling and education in many ways. But I think fundamentally what the issue is access to some type of rudimentary device. And I bring this up because I think in the field of audiology and acoustic sciences, there's always this pursuit of perfection. We want the absolute best, right? And we heard a lot of it from Cindy today, what can be done absolutely the best. And it's all we want, it's ideally we want for ourselves. But I sort of bring this analogy back to the idea of like, if you want to get somewhere, ideally you want your whole, your tricked out car with everything, right? But sometimes you just need a scooter, right? And I think fundamentally the way we approach hearing healthcare right now is that you either have everything or you have nothing, right? And I think that's why PSAPs come up a lot, because a lot of times you say, well, you can't afford a hearing aid, we can't get back and forth, but maybe use a PSAP at least, right? And I think, 37 years ago when the 1977 task force was convened by the FDA, I think there were real issues with the PSAPs back then, or let's say personal amplifiers back then, with issues of safety and efficacy. But I think increasingly with technology, just literally in the last 5 years, that the gap between what can be called, quote unquote, a PSAP and a hearing aid is increasingly narrowing to nothing, right? Essentially, right? It depends how you market and how you label it. And I think that I don't have a good solution to this. And Eric, I appreciate your comments on this because I think it's a different mindset for the FDA to think about this. But fundamentally, where I come from as sort of an epidemiologist or public health specialist, or as an otologic surgeon too, is I think fundamental issues of access. And that's why I brought up the idea of the over-the-counter hearing aid yesterday. I think when I mean over-the-counter, I should clarify a little bit. What I fundamentally mean is some type of device which is limited in its output in terms of compression and output. So from a safety point of view, I don't think it's necessarily an issue. From efficacy point of view, I would always argue something like that is better than nothing, quite simply, right? Except right now, there is no access for a patient who has a hearing impairment, which 2/3 of all of us will have as we age, to get access to such a device. So my question is, what can we do from a regulatory point of view to make access to such devices possible?
Thank you very much for that question. And I think we all appreciate the need for access to amplification as the population ages. And I'm glad we're having this discussion. From a practical standpoint, from a regulatory standpoint, we don't make the distinction between a kind of a starter hearing aid and a more advanced hearing aid for a moderate to severe hearing loss. I mean, the regulations define a hearing aid as a wearable instrument that is intended for hearing impaired individuals. So we don't slice and dice and say this group for starter hearing aids is not subject to the regulations and the other is, okay? But that being said, I do understand that there may be some barriers created by the regulations regarding conditions for sale. I don't think the labeling regulation has been a huge issue for anybody, but the conditions for sale certainly has been a hotly debated provision over the years. I would point out, however, that the regulations as they exist are not incompatible with a direct-to-consumer marketing model. Okay, and this has actually been done and is being done. As long as the labeling requirements are met, as long as there is a signed waiver, and we've been fairly liberal in terms of interpreting this, or as long as it's an electronic signature, as long as the patient has the opportunity to review that user instructional brochure, as long as the record-keeping requirements are complied with, a manufacturer can directly market to a consumer over the internet, via email, so forth, okay? There is still a burden in terms of getting that waiver. It's not, from the FDA's perspective, it's not in the patient's best health interest to do that. But in the preamble to the original regulation, it was acknowledged that some people have religious beliefs, some people have personal beliefs that would prevent them or would make them less likely to want to do a medical evaluation, and the regulations accordingly have a waiver. Unlike the case for some of our European colleagues, as I heard yesterday, it sounded like it was more of a, the ENT physician is the gatekeeper essentially in some countries, and you have to see that individual before you are eligible for a hearing aid in order to rule out those medically treatable causes of hearing loss. So I would just point out that the system as it exists is not perfect. We recognize that. There are a large number of people who are opting out for waivers at this point. And you could debate whether or not even just signing the waiver is of some benefit to the patient in terms of actively informing them that if a waiver is done, well, in terms of actively informing them that there are conditions potentially that could be treatable surgically or medically that they may be missing if they opt to forgo that, and then they get the hearing aid, they're not getting better, or perhaps they're getting worse. Hey, I really should go see a physician as a result of that counseling process. So it's a complicated issue. We're willing to listen to different perspectives on this. There certainly is a process, kind of a cumbersome one, to change regulations, but it exists. So as our understanding of this area increases over time, and there's an interest, or there's certainly a citizens petition route to propose alternative ways of regulating hearing aids.
Thanks.
Anna Gilmore Hall, Hearing Loss Association of America. Very good panel, and I really appreciate we're starting off the day with this kind of conversation and dialogue. I have a question and then a follow-up. Are eyeglasses and contact lenses regulated by the FDA? And if so, is the process by which those accommodations were made for opticians, optometrists, and ophthalmologists relative to prescription and distribution and of eyeglasses and lenses, a process that we could learn from as we grapple with this whole PSAP and hearing aid process?
Thank you. That question does come up quite a bit in terms of the analogy of eyeglasses, which are certainly available over the counter, and hearing aids. And I'm not familiar with the ins and outs of historically how that decision was arrived at. I think part of the difference between the situation of a pair of reading glasses and an over-the-counter hearing aid without any kind of medical evaluation or waiver has some degree to do with the degree of an individual to appropriately self-diagnose their condition and to appropriately select whether the eyeglasses are an appropriate solution for their particular health situation. So I think most of us recognize that eyeglasses are a very simple technology. They're magnifying glasses. I think most of us realize when you turn 40 years old, as I did, and are holding the newspaper more and more like this, I mean, there's not a lot of conditions, in speaking to my ophthalmology colleagues, that manifest that way, that respond to reading glasses. And I think the feeling is that is a relatively self-diagnosable condition for consumers. Hearing loss, on the other hand, is a bit different in terms of you can have a hearing loss from many causes, from something as simple as a cerumen impaction, which certainly doesn't present a safety concern with use of a hearing aid, but I don't think anybody thinks that's a particularly good approach to dealing with that particular condition. And then at the other end of the spectrum, you have more concerning things: cholesteatomas, tumors, fusions related to nasopharyngeal tumors, all those kinds of things, which admittedly are rare, but they are present, and they would potentially be detected by a medical evaluation. Compounding that is the fact that many of those conditions, which are medically and surgically treatable, would in fact improve with a hearing aid. So it's not like a failure of a hearing aid would trigger this person to necessarily go and be evaluated for that condition. So I think these are concerns that were taken into consideration when developing those regulations. Admittedly, I was not around when that happened, but this is just my reading of the preamble of the regulations and some of my thoughts.
I appreciate that, and I appreciate your comments. I guess what I'm trying to get at is, since this is such a complicated issue for consumers and for providers, is there something that we can learn from the process about how those decisions were made in sort of a new way of thinking about this versus just sort of hanging on to the way regulations have been developed and implemented today? I'm just trying to help everyone think about this in a new way from a process point of view, not from such a narrow regulatory point of view.
Yeah, and I appreciate that, and I have to admit I don't know a lot about the process that was used in that eyeglass issue. But in general, when we contemplate changing a regulation, particularly one that has been in place for so many years, that was implemented in response to an interdepartmental task force that I mentioned and Senate hearings and so forth. I think it's incumbent on us as a regulatory agency to, as much as possible, base those kinds of changes and modifications on science-based grounds. And it may well be that the science has changed since 1977, and it's something to revisit. And if that's the case, we do have the citizens petition process. We have FDA advisory panels that we can get their clinical input on, and certainly we are willing to do so.
Okay, so this is for all of you, if you have any ideas. And there's a statistic which is more or less that the average age at first time hearing aid use is about 70. The audiology clinic that I'm working with now in a geriatric hospital, the average age of their audiology patients is over 85. And there is a high co-occurrence with clinically significant cognitive loss. So Eric mentioned special populations could put a different lens on some of the considerations. I don't know what you meant by special populations. Cynthia talked about, appreciating the context of the individual. I think Fiona also may have some thoughts about the different sectors of the population and the aging population possibly having different needs. So if we think about people who have hearing loss, but they also have cognitive loss, which is going to affect how they may be able to use a technology, what they're using the technology for, whether they're using this hearing aid thinking it's going to deal with their memory issues, or they're using a memory device thinking it's going to, the functionality of these devices gets overlapped. Older people can't understand the instructions in the brochures. So do we need to worry about aging and the comorbidities with other impairments as we embark on actually trying to figure out what to do with these with that generation, that age group?
As you were speaking, I was reminded of a patient I saw once who was an elderly man. He came in with his son who was 60, and he came in with his wife, and they'd been married for 60 years, and he referred to her as his bride. I get a little emotional when I talk about that.
Was that my dad?
He couldn't hear. He had a lot of brainstem injury due to repeated strokes, and hearing aids, were not an option. He needed remote microphone technology. So I had to think outside the box, and I was thinking to myself, is it legal to fit this guy with just an FM system and earphones? What the heck, I'll try it. And I put the earphones on him and started, and he was sitting in a wheelchair, by the way, and he has visual problems, so captioning would not be an option for him. And he hadn't really talked to his family in like 5 years. And so he was very quiet, and I put the headphones on, and he just perked up. I asked him what he had for breakfast. He starts rattling off. His wife was like in shock. His son was in shock. Long story longer. His wife was very savvy. She was in her late 70s, but I gave her instructions on how to use the FM. I drew PowerPoints on how to hook it up to the TV, and he lived 5 years longer and had a great life. But it really was a challenge to think of all the different factors to make this work. And I had to find out about their lifestyle. You really know people once you ask all these questions. And they like to sit in their living room watching TV, his wheelchair, her chair, and a coffee table. So I added an extra microphone. And she got control of the remote because she knew she had to mute the TV before she spoke to him. So she liked that. And, those are the people you run into every once in a while. And that is an issue. I don't know if I answered your question, but.
I think we just need to think a whole lot more about it, as opposed to saying, yeah, this is what we've got, but, it's too much to adapt it given your other special needs, and so you get nothing. It's an extreme case of you get nothing, because we can't do the complex thinking you just described?
Yeah, I always think of what's out there. Okay, what's the need? Okay, what can I take out there? How do I adapt what's out there? Maybe there's something else I need to find out. I once had a deaf Gallaudet student who wanted to be a cameraman, and this was before they had cameraman systems where you could read captioning between him and his director. And so I worked with Oticon, and we developed a two-way communication system with direct audio input to hearing aids. But I also had to get a list. I had to learn what it's like to be a cameraman and what words are used. And we had to find vocabulary that he could understand without visual cues. And he got a job with C-SPAN and worked there for 3 years. So that was another interesting adaptation.
I think I'd like to offer an answer to that from the more collective perspective that is health technology assessment. And it's what I was trying to flag in talking about downward substitution and the fact that insurers, including in the US, are paying for the bulk of our health care. So the point of saying that is to say that they will pay for our health care as we age, whether we age well or badly, and whether the comorbidities pile up, and as they will, but pile up in ways that are accelerated. So one of the questions that I would ask when you're talking about the gentleman with hearing loss and cognitive impairment is which came first and what has accelerated what. So the point of downward substitution is for healthcare systems, for health insurers, public or private, to be recognizing the need to invest, to downwardly substitute, to invest in lower tech supportive care to support healthy aging. That was the point I was trying to make. So I think that's my response to that you're right, clearly our systems are not doing well, apparently here and certainly back home, as well as they need to do in addressing supportive, in investing in oftentimes things that are seen as consumer items. They're not, providing a very, very important thing to keep people healthy at home and in their homes and living in the communities is, in Canada, clearing the snow, right? This is or picking up groceries. This is not a healthcare investment in our traditional terms. But when you're talking about healthy aging, it is a healthcare investment because it's the kind of investment that keeps them healthier, longer, and in their homes and reduces upward substitution, which is a fall and a crisis and extremely expensive long-term care or care in a rehab hospital. So I think my response to that is about the policy challenge that I think you're engaged in here, and is to talk about the importance of investment in these kinds of supportive technologies to support healthy aging and to keep people at that supportive care stage as long as possible.
And I would just add from a regulatory standpoint, I don't know if you were asking this or not, but in terms of the new populations and so forth, if a manufacturer actually wanted to market a hearing aid as a device to slow or stop, exactly, to slow the progression of cognitive impairment, that certainly would be a new indication, potentially a new intended use for the device. And would probably not even be within the hearing aid category anymore. And we have mechanisms of dealing for that, but it certainly would need to be supported by clinical data as well.
I think we have time for one more question, and then we'll be taking a break.
Okay, well, I'd like to throw out a question about unintended consequences, and I really don't have the answer on this, but right now, and this is current data, to introduce a wireless device for international markets, US, Canada, Europe, Australia, New Zealand, the regulatory testing cost is over $100,000. You add FDA testing and comparable stuff for CE marking and so forth, we're probably talking $150,000, $200,000 of hard lab costs, regulatory fees, include in there the certification Bluetooth Wi-Fi. And all of those have very good reasons for existing, but the question is, are we really where we want to be, and aren't we, in an unintended way, killing innovation, ensuring that companies will not put as many products on the market? They'll group products, perhaps where more products would better serve the population because of the cumulative regulatory cost. And
I think this is a classic countervailing powers question, right? So the higher But it go. So what you're saying is industry has to pass these hurdles to get things onto the market. And what that means is that the small mom and pop shop will not be successful. And I guess the question is, do we want the small mom and pop shop to be successful at the end of the day, if what that requires is that on the market are things that pass no meaningful regulatory hurdle? And I'm placing a higher burden for the HTA perspective, a higher hurdle, if we then want to actually invest in this for a population, which is what our healthcare insurance pools do. So I would argue that you're absolutely right. It creates that consequence. It is the higher the regulatory burden, the higher the standard needs to be, and the bigger the industry, the bigger the company needs to be to actually meet that. But obviously, it is also selling its products at those prices, and obviously you can't have the smaller companies will not succeed. And we are seeing, pharmaceuticals have gone through that, clearly. They are not mom and pop pharmaceutical companies that there were at the turn of the 20th century. MedTech is moving in that direction too. We're seeing much more merging of companies, much more of a growth of a multinational MedTech sector, in part in a response to that regulatory requirement, which I think many, if not all, though not all, consumers would want.
If I could just throw in one other comment, there's also a chilling effect to a company's willingness to explore something where they don't know the market. You know, someone has an idea, they don't know if anyone will buy it or not. You have to think real long and hard before you'll go explore that.
Okay, listen, thank you very, very much. We've had some really stimulating discussions this morning. We need to have everybody back here no later than 10:55 promptly, please. Thank you.